In addition to the clinical features, age, Rayer-Benet stage, routinely available clinical lab testing, beta-2 microglobulin immunophenotyping, I will routinely also get TP53 assessment, and that's both by assessing for deletion 17p with FISH panel, as well as looking for TP53 mutations, in addition to the IGHV mutational status. And these don't change the indications for treatment outside of an early intervention study, which remain with the IWCLL 2018 guidelines, but they do inform the treatment decision, and so that would certainly lead to a more strongly worded recommendation against a chemoimmunotherapy approach when discussing that with patients, but even furthermore when deciding between our more go-to novel agent-based options of a continuous BTKI versus a venetoclax obinutuzumab CLL14 time-limited based approach, that would play into the shared decision-making with the patient and maybe lead me to favor the BTKI approach currently. I think beyond treatment decision-making at that time, there could be perhaps a more provocative comment on obtaining those even at diagnosis. And that would be to really guide prognostic discussions with the patient, facilitate the use of the CLL-IPI, which requires those variables to calculate. And so depending on the goals and values and preferences of the patient, obtaining those even early on could be helpful in how to follow them, and also eligibility for early intervention studies. As far as things like next generation sequencing, which certainly are being used quite a bit in the research setting, but not quite yet prime time in routine clinical practice, both clonal and subclonal mutations in various recurrently mutated genes in CLL, SF3B1, Notch1, ATM. That's certainly an area for the future, as well as just altogether tumor mutational load in patients. So certainly things that I look forward to seeing incorporated more routinely into practice in the future.